For expiration, all we have to do is relax the muscles of inspiration, as we indicated earlier. This relaxation will cause my inner pleural pressure to go from -8 back to its original -5. So notice, as inner pleural pressure goes from -8 to -5, then that means the transmural pressure gradient is going back down. Instead of being 8, it's now 5. So I have less force pushing out. This less force pushing out, that just means a drop in transmural pressure gradient. Alveolar volume goes down, therefore the pressure goes up, and because the pressure went up, air flows out of the lungs. And that's how we get the air out. And air flowing out will ultimately get the alveolar pressure back to 0. Once alveolar pressure is 0, there's no more airflow. And where does the system go to? FRC. Take away all external influences and you go to FRC because that's equilibrium for the respiratory system. So that's our normal inspiratory-expiratory cycle. Okay, what we just described in words, we're going to now see on a graph. Upper graph is volume, below that is interpleural pressure, then we have airflow and alveolar pressure. We start first with contracting. External intercostals, diaphragm makes interpleural pressure more negative. This increases the transmural pressure gradient, which distends or expands alveoli. Therefore, alveolar pressure becomes subatmospheric. Notice in the panel right above it, flow occurs. The flow is going in, and the top panel shows the volume of air that goes in. Notice as we get to the very last part of that green, that represents the end of inspiration. Airflow returns back to 0 because alveolar pressure at end inspiration, as we indicated on a previous slide, alveolar pressure at end inspiration is now 0, or in other words, atmospheric. Therefore, there is no flow. We now relax these muscles. Interpleural pressure goes back to its original level. This decreases the transmural pressure gradient. So alveolar volume goes down. Therefore, alveolar pressure goes up. Notice in the panel above alveolar pressure, the flow is going up. And in the top panel, that volume that goes out is the tidal volume. So this is our inspiratory-expiratory cycle. Now, one of the things I don't want you to get bogged down on is that flow. You notice that it says minus and plus. Well, it's just how the system's set up. Okay, you could make a plus be flow in, or you could make a minus on that value be flow in. Either way, and it doesn't really matter. So don't get lost on that idea. Please don't get lost on that idea. That's not a high yield point. That's not something for you to get disturbed with. So here are changes that we've discussed. This is negative pressure breathing. This is how we get air in and out of the lungs. All right, we're going to continue with the idea of the transmural pressure gradient, although now we're going to apply it to the cardiovascular system. We're going to talk about cardiovascular changes during inspiration, things to think about, solid information for USMLE Step 1. As we indicated, during inspiration, interpleural pressure becomes more negative. That means the transmural pressure gradient across the alveoli went up. Well, remember, interpleural pressure is the outside pressure for everything in the chest, including the vasculature. So, because interpleural pressure is becoming more negative, the transmural pressure gradient is increasing across the vasculature. That's going to cause the great veins and right atrium to expand. If they expand, then pressure inside of them, intravascular pressure, is going to go down. Well, if that pressure goes down, remember that's the downstream pressure for venous return. So if that pressure goes down, I have a bigger pressure gradient driving venous return to the right heart. So systemic venous return and right ventricular output will go up because I have more venous return. I increase preload, I'll increase output. Stroke volume's going to go up on the right side. That's Frank Starling. As we did discuss in the previous cardiovascular section, this creates the physiologic splitting of the second heart sound, because this increase in volume to the right heart delays the pulmonic component. This increase in volume to the right heart delays the pulmonic component. Now, pulmonary vessels are going to expand. When we think about the pulmonary circulation, we think of veins, even on the pulmonary artery side. So both arteries and veins, the transmural pressure gradient is going to go up. So that vasculature is going to expand, increasing the volume in the pulmonary circuit. All right, let's think about that. Both artery and venous side. Both artery and venous side. So I'm not increasing the pressure gradient. I'm just increasing the total volume in the pulmonary circulation. And if I'm increasing the volume in the pulmonary circulation, I'm going to reduce venous return to the left heart. It's kind of like venous pooling when we stood up for gravity. We're going to get vascular pooling in the pulmonary vasculature, and that's going to decrease venous return to the left heart. We'll continue on with this on the next slide. So as we indicated in the last part of the last slide, venous return to the left heart goes down. Well, Frank Starling, the heart don't get it, the heart don't pump it. That means reduced output of the left ventricle. This is going to decrease arterial blood pressure. Now, in addition, this inspiration will reduce vagal outflow to the heart, and you'll start getting a slight rise in heart rate. This is called a respiratory sinus arrhythmia. So breathing in reduces vagal outflow to the heart. The exact mechanism is very controversial. Okay, if you want to just remember it because arterial blood pressure is going down, could be a barrel reflex. It could be, some people believe that. But there are other factors going on that may contribute to this, or may be the mechanism for it. Regardless, bottom line, inspiration reduces vagal outflow to the heart. So during inspiration, you get a little increase in heart rate. This is called a respiratory sinus arrhythmia. And that can change heart rate. And so sometimes people have very strong respiratory sinus arrhythmias. And so you want that to go away in order to get a good baseline heart rate on somebody who's undergoing an EKG. Now, hopefully it will make sense to you that the cardiovascular changes during expiration are just a reverse of what we just said. Interpleural pressure moves towards zero. In other words, it becomes more positive. Transmural pressure gradient returns to its original level. Pulmonary vessels are no longer going to be distended. They're going to be compressed. In other words, we're going to have elastic recoil occurring. So volume of blood in the pulmonary circuit decreases. Where's that volume going? To the left heart, to the left heart. Therefore, systemic arterial pressure rises during expiration because I have greater venous return to the left heart. So aortic pressure is going to go up, particularly systolic. The vagal outflow returns. Again, that mechanism is debated, which is going to reduce heart rate. So that's part of our respiratory sinus arrhythmia. Goes up a little bit in inspiration, then back down in expiration. Now, another thing to remember is something called the Valsalva maneuver. A Valsalva maneuver is a forced expiration, and as we will discuss in pulmonary function testing, when I perform a forced expiration, I take the chest and I compress it down and in. So I'm just pushing the chest down and in. This creates a positive interpleural pressure. All right, interpleural pressure is the outside pressure for everything in the chest, including the great veins. So if interpleural pressure becomes positive, you can markedly compress the great veins in the chest, markedly reducing venous return. And if I reduce venous return, then I'm going to reduce cardiac output. And if cardiac output falls, then blood pressure can fall. The Valsalva is sometimes called the bearing down. So you're making a forced expiration, but you don't allow air to come out. And people can pass out from this, because if you hold that for a long enough period of time, this reduction in venous return can get severe enough that blood pressure falls enough that you get a syncope event. So those are our cardiovascular changes during inspiration and expiration. Okay, previously we talked about, just finished up, was the idea of negative pressure breathing. Now we're going to put someone on a ventilator and have positive pressure ventilation. And that's what's illustrated on this slide. In the green, we have assisted control mode ventilation. Now, I wouldn't get too bogged down in all the various types of ventilatory mechanics and ventilatory aspects like BiPAP, etc. And so you shouldn't get too bogged down on this assisted control mode ventilation. At the arrow, the patient initiates an inspiratory effort, and then the ventilator kicks in, and that's what drives ventilation. If you notice on the next curve, the next ventilatory curve, the patient doesn't initiate it, and then the ventilator goes ahead and initiates an inspiratory-expiratory cycle. So the patient tells the ventilator it's time to breathe, but in case the patient doesn't, then the ventilator goes ahead and kicks in, and that's all that's illustrated there. Now, the difference between negative pressure and positive pressure breathing is, notice, again, the green curve for now, notice we are making airway pressure positive for inspiration. So we're putting a positive pressure at the mouth and forcing air in. Effectively, just think like a big syringe. You're just pushing on the syringe to push the air in. Now, once we take away that pressure at the mouth, then airway pressure falls and we have a passive expiration. Now remember, where do we go back to when we take away all external influences? Where does the respiratory system go? Exactly, FRC, FRC. And so zero pressure at the mouth here represents FRC, just as it would in negative pressure breathing. So the patient now is at FRC when the green line gets back down to 0. Now, a type of ventilation you should appreciate for step 1 is called positive end expiratory pressure. Beep, beep. Yeah, it's called beep. You have to admit these respiratory lingos are pretty darn great. Beep, beep. Positive end expiratory pressure. That's the blue curve. Now notice on the blue curve that during expiration, pressure at the mouth is still positive. It's +5. So we're keeping positive end expiratory pressure. So we always have a pressure that is positive in the airways. Since we're at +5, then we're not returning to FRC. So one of the downsides of positive end expiratory pressure is that you don't return to FRC. And remember that pulmonary vascular resistance is lowest at FRC. So during PEEP, we're going to have an elevated pulmonary vascular resistance, which will reduce venous return to the left heart. In addition, we're not doing the same breathing pattern. In negative pressure breathing, we're pulling the chest up and out, making the interpleural pressure more negative. Well, now we're pushing the chest out, but we're pushing it from within. Just imagine that we're pushing air into the lungs, the chest cavity expands, but that's because it's being pushed from the inside. Well, that push from the inside is driving us toward a positive interpleural pressure. So during mechanical ventilation, positive pressure breathing, during the inspiratory cycle, you're tending to make interpleural pressure positive, which gets exacerbated with PEEP. Notice the higher airway pressures during inspiration, plus we have a positive end expiratory pressure. So interpleural pressure is going to be positive. That's going to tend to compress the great veins in the chest, reducing venous return to the right heart. So we have reduced venous return to the right heart. We have increased pulmonary vascular resistance. So PEEP is going to decrease cardiac output. Put a patient on PEEP, you're going to decrease cardiac output. Now you may be asking, well, why would you ever want to put someone on PEEP? Well, the rationale for that is if we have high recoil forces in the lung. and we're worried about atelectasis. PEEP helps prevent atelectasis. So like in conditions of adult respiratory distress syndrome, you're going to keep that positive end expiratory pressure in order to try to prevent atelectasis. The idea is you're going to trade off a little cardiac output to make sure that we still have ventilation of the alveoli. Breathing is a good thing. Another mode of ventilation to know for step 1 is called continuous positive airway pressure, CPAP. CPAP. Again, kind of beep, CPAP. Oh, these are great. These are great. CPAP. CPAP is similar to PEEP because we have a continuous positive airway pressure, but the big difference is the patient breathes on their own. So you notice on the left-hand side of the curve, pressure at the mouth is 5. The patient makes an inspiratory effort, so airway pressure falls some, but it never becomes subatmospheric. It never becomes subatmospheric. And we use CPAP. We use CPAP for obstructive sleep apnea. An important disturbance or problem with the respiratory system, you could call it a pathology if you wish, is a pneumothorax. By definition, a pneumothorax is air in the interpleural space. How can we get a pneumothorax? Well, trauma due to perforation of the chest wall. Okay, imagine a gunshot wound or a knife or something that penetrates the chest wall from outside, and also spontaneous rupture of alveoli. Now, if we breach the chest wall and open that space, then interpleural pressure is going to go from -5 to atmospheric pressure. The reason is because there's a pressure gradient for air to flow. So once I open the chest wall and expose the interpleural space to atmosphere, air is going to flow in, and it's going to flow in immediately. And it will flow until there's no longer a pressure gradient. In other words, when interpleural pressure equals atmospheric pressure. Well, since alveolar and interpleural pressures will be the same, they'll be atmospheric, the transmural pressure goes to 0 and the lungs collapse. This collapse of lungs we call atelectasis. Now, the chest wall is going to spring out, because remember, the chest wall is always trying to spring out. When I remove that inward pull of the lung, because they've collapsed, the chest wall will spring out, or in other words, the chest wall will in fact expand. Now, a different type of pneumothorax is called a tension pneumothorax. In this, we have an opening of the lung to the pleural space from inside, and it will function as a valve, allowing air to move from the alveoli into the pleural space, but not exit the pleural space. We're going to make strong inspiratory efforts. This is going to promote air to enter into the interpleural space, but that valve closes during expiration, and we're basically just trapping air in the interpleural space. As a result, interpleural pressure becomes positive. All right, interpleural pressure becomes positive in a tension pneumothorax. We are trapping the air in the interpleural space. This ventilation is going to go down on the side of the tension pneumo because I have a positive interpleural pressure, which is going to tend to compress the small airways. Also, this positive interpleural pressure is going to decrease venous return. Just as we mentioned several times, that interpleural pressure is the outside pressure for everything inside the chest. So when interpleural pressure starts to become positive, we're going to compress the great veins, decreasing venous return and decreasing cardiac output. Most common cause of a tension pneumothorax is a patient on a ventilator, positive pressure ventilation. Now, some of the key clinical signs to look for, clinical vignette on step 1 for a tension pneumothorax, is the patient will be in severe respiratory distress. They will be trying to breathe. They will be trying to huff and puff. There will be an asymmetry of breath sounds on the side of the tension pneumo. As I indicated, we're going to compress the small airways. You won't be able to move air on that side very well, so you won't hear breath sounds on that side. In addition, you're going to deviate the trachea. This positive pressure is going to push the trachea. It's going to cause it to deviate to the side. And it's going to deviate opposite of the tension pneumo. So in other words, if I have a left side tension pneumo, I'm going to push the trachea toward the right side. So that deviation of a trachea, asymmetry of breath sounds, respiratory distress, it's all telling you tension pneumothorax. One of the things to appreciate in a tension pneumothorax, as we indicated on the previous slide, this positive interpleural pressure is going to markedly decrease cardiac output, and this will just continue to get worse and worse and worse. So we needle aspirate or put a chest tube in order to relieve that positive pressure in the interpleural space. So that's what's happening in a tension pneumothorax. All right, here's a lung compliance curve. Notice on the y-axis we have lung volume. On the x-axis we have interpleural pressure becoming more and more negative, and thus lung volume goes up and up and up because we have greater and greater transmural pressure gradient. The x-axis we could change and put in positive numbers and call it transmural or transpulmonary. Since we have the change in volume, change in pressure, the slope of this line is compliance. Now, very big point for respiratory. Notice, at low lung volumes, we have a very steep curve, so we have high compliance. However, as we start to approach total lung capacity, notice how the curve flattens out. So at high lung volumes, we have low compliance. So again, low lung volumes, high compliance. High lung volumes, we have low compliance. Now, let's flip and use that other word, elasticity. Elasticity, which is the inverse of compliance. So notice, at low lung volumes, we have high compliance. This means low elastic recoil, or a low elasticity. As lung volume goes up, compliance goes down. That means we have high elasticity. So at high lung volumes, we have high elasticity. At low lung volumes, we have low elasticity. One of the things to appreciate here, notice, as lung volume falls, elastic recoil falls. So elasticity, recoil, we're using those terms synonymously. Notice, as lung volume falls, recoil falls. Because elasticity is high, elastic recoil is high at high lung volumes. Elastic recoil is low at low lung volumes. All right, let's bring in the pathologic changes that occur for the respiratory system with respect to lung compliance. Our normal curve is in the purple, but notice the green curve. This would represent an example would be interstitial pulmonary fibrosis. Really all the restrictive diseases, asbestosis, silicosis, sarcoidosis, all of these push down or compress or decrease the change in volume to change in pressure relationship. In other words, we have reduced compliance. We have reduced compliance, which means we have high elastic recoil. So in these pulmonary diseases, like interstitial fibrosis, they are characterized by reduced compliance. We put these all together and label them as restrictive diseases. The lungs are restricted from expanding. The lungs are restricted from expanding. This is very similar to the idea of restrictive cardiomyopathy. It's difficult to fill a ventricle in restrictive cardiomyopathy. Only that's blood. Well, same concept here. In restrictive pulmonary diseases, it is difficult to fill the lungs with air. So they're going to be characterized by reduced compliance or increased recoil. Our other example here is emphysema. That's the blue line. Notice that compliance has markedly increased. In emphysema, we're getting destruction of the interstitium of the lungs. The alveolar septa are being destroyed, and so we have less and less inward recoil of the lung. As a result, that means we have increased compliance. Emphysema is one of our obstructive diseases, and obstructive diseases are characterized by increased resistance to airflow. And the main pathology for an emphysema patient is associated with this lack of recoil. Very high compliance, low recoil. All right, low recoil. All right, let's talk about the components of lung recoil, elastic recoil. These are the collagen and elastin fibers of the lung. And as we indicated before, the larger the lung, the greater the stretch, the greater the recoil. So at high lung volumes, we have high recoil. Now, it turns out that it's not the collagen elastin fibers that are the predominant components of lung recoil. The predominant component of lung recoil is surface tension forces in the alveoli. Surface tension is created where we have a liquid-air interface. So when air and liquid see one another, we generate surface tension forces. These are very, very strong molecular forces. And the resolved direction of those is inward. The resolved direction of those is inward. In other words, in alveoli, they act to collapse the alveoli. Surface tension forces are the main component of lung recoil. Okay? Lung recoil. This relationship can be expressed when we think about the law of Laplace. Tension equal pressure times radius. If we just rearrange that, we know that the pressure is proportional to tension divided by radius. So the greater the tension, the greater the pressure in the alveolus because of these elastic recoil forces associated with surface tension. How do we know that surface tension is the predominant component of recoil? Well, we've demonstrated experimentally, but we also have a couple of important clinical conditions. Infant respiratory distress syndrome, in which surfactant is deficient or not functioning properly. These infants, typically associated with premature infants, do not have adequate surfactant. All right, let's back up. What does surfactant do? Surfactant is that highly lipid molecule that interferes with surface tension forces. So if we don't have surfactant, we're going to have a lot of surface tension forces and thus a very high recoil, or in other words, low compliance. As a result, the work of breathing is just enormous, Again, all muscles associated with moving air for the respiratory system are skeletal muscle, and that skeletal muscle can fatigue. And so even if you could move air, the muscles would become exhausted because the work of breathing is so great. Here's a beautiful example of when you might use PEEP. Because of the high recoil, you are worried about spontaneous atelectasis. The other one that kind of mirrors this in the adult is adult respiratory distress syndrome. We mentioned in cardiovascular. This is an acute lung injury. One of the more common causes to think about for ARDS is sepsis. Here we have an injury to the pulmonary capillary endothelium. This will lead to interstitial edema and increased lymph flow. This injury and increased permeability of the alveolar epithelium lead to protein leakage into the interstitial space of the lungs and reduces the efficacy of surfactant. And as a result, lung recoil goes up, just like if we don't have it, in the example being infant respiratory distress syndrome. If we reduce the efficacy of it, same kind of scenario, big increase in recoil forces. Gastric aspirations can also cause a direct injury to the lung epithelium, increasing permeability and creating edema. And again, here are examples. This ARDS would be another example where we might use PEEP because we're reducing lung compliance, increasing elastic recoil. We are worried about spontaneous atelectasis, and thus we use PEEP, PEEP. This is a graph to kind of illustrate the idea of respiratory distress syndrome. So the blue line represents our normal. Notice how the curve gets shifted down and to the right. In A, so this is a patient starting to suffer from respiratory distress syndrome. Notice here on the x-axis, instead of having interpleural pressure, as I mentioned on the previous compliance curve, we could put transpulmonary pressure or we could put transmural pressure gradient. So by decreasing the slope of that line, compliance is going down. The lungs are getting stiffer. They're more difficult to expand, which means elevated recoil. Now B shows the concept, and this is an important concept, that if alveoli become atelectic, it takes a lot of distending pressure, a lot of transmural pressure gradient or transpulmonary in order to open them back up. So notice that very high level of transmural pressure needed to open a collapsed alveoli. So we're really trying to work to make sure that alveoli don't collapse because they're so difficult to open back up. All right, elastic recoil, overcoming the elastic forces, is one component to the work of breathing. The other component is airway resistance, pressure flow resistance, pressure flow resistance. Yeah, just like we discussed in cardiovascular. Only here, this is air that's flowing, not blood. Remember still, resistance is inversely related to the radius to the fourth power. Now it turns out the first and second bronchi is the site of most of the airway resistance. Okay, that doesn't seem to jibe up very well with the idea of resistance being inversely related to the radius to the fourth power. So how do we reconcile this idea? Well, the answer here is turbulence. The answer here is turbulence. These airways have a pretty good sized diameter, and we have a lot of velocity, very high velocity. So big diameter, high velocity, Reynolds number is high, and we get turbulence. Two big things associated with turbulence is you can hear it. Yeah, you can hear breath sounds, but it also markedly increases resistance. So that's why most of the resistance is here in these larger airways, because of turbulence. All right, autonomics, parasympathetics. Bronchoconstriction occurs via parasympathetic stimulation. This is the M3 muscarinic receptor. In addition, M3 stimulation increases airway secretions. So parasympathetics bronchoconstrict and increase airway secretions. Again, M3. M3. Going the other way, bronchodilation occurs as a result of catecholamines, more specifically epinephrine. Because the airways express the beta-2 receptor, epinephrine stimulates beta-2 to cause relaxation of smooth muscle. That's a GS, cyclic AMP pathway. What's one of the first drugs you give in anaphylactic shock? Yeah, epinephrine. Epinephrine for that bronchodilating capacity of epinephrine. Again, that's beta-2 receptors. A very important concept in respiratory is illustrated on this slide. Notice what this slide says. We have lung volume on the X, airway resistance on the Y. As lung volume goes up, airway resistance goes down. So there's an inverse relationship between lung volume and airway resistance. Again, there is an inverse relationship between lung volume and airway resistance. All right, what is the mechanism for this? Well, let's do that on the next slide. Two things provide the mechanism for why, as lung volume goes up, airway resistance goes down. The first is the transmural pressure gradient. Remember that in order to get to high lung volumes, interpleural pressure becomes more and more negative. This increases the transmural pressure gradient across alveoli, but it also increases the transmural pressure gradient across small airways. Because we have a greater transmural pressure gradient, they expand and resistance falls. So one mechanism for the inverse relationship between lung volume and airway resistance is the transmural pressure gradient. The second is a mechanical, we call radial traction. Walls of alveoli are connected to small airways. Therefore, as alveoli expand, They literally pull open small airways. By pulling open the small airway, it increases the radius, which in turn reduces the resistance. So again, our two mechanisms for this mechanical effect: as lung volume goes up, airway resistance falls. Greater transmural pressure gradient, and the structural component, radial traction. Okay, now let's do a little pulmonary function testing. You know, in pulmonary function testing, you take a deep breath in and then you blow it out as hard and as fast as you can. And you know, if you've ever done this, this will resonate to you. What's the technician doing? She or he is screaming, blow, 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 and they're just, you know, they're really encouraging you to blow hard, because it's very important that you make a maximal forced expiration. All right, what do we see on pulmonary function testing? Here's a graph illustrating this. Notice that we take a deep breath in all the way to total lung capacity. So in this individual, it would be 6 liters. Then we blow out until we can't blow out any more air. The volume that was blown out we call the forced vital capacity. It is vital capacity, it's just being forced out. That's why we call it a forced vital capacity. In this example, it's 5 liters. Forced vital capacity is a volume. Next key characteristic we look at is something called the FEV1. In this example, it's 4 liters. FEV1 stands for forced expiratory volume in 1 second, or the first second. So notice this subject blew out 4 liters of the total of 5 in the first second. So what we do is we take that and make it a ratio, the FEV1 to FVC ratio. When we make this a ratio, it turns it into a flow parameter. All right, it turns it into a flow parameter. Notice what we have from pulmonary function testing. We have flow and we have volume. Restrictive diseases are characterized by reduced compliance. So what's going to go down? The major factor? Volume. Obstructive patients, this is characterized by increased airway resistance. So the factor that's going to go down? Flow. So flow down in obstructive, volume down in restrictive. That's how it works out. Again, highly diagnostic. All right, let's talk about the physiology of pulmonary function testing. On the left would be a passive expiration. Okay, we start at the end of inspiration. We've taken a deep breath in. We have a very negative interpleural pressure, and thus a very positive transmural pressure gradient. Then, if we were to passively breathe the air out, okay, not force it out, interpleural pressure would remain negative the entire time, and we would go back to FRC. For pulmonary function testing, we're going below FRC. We are blowing out that expiratory reserve. We do that by contracting abdominal and internal intercostals, compressing the rib cage down and in. This results in a positive interpleural pressure shown on the right. So during a forced expiration, we're going to make interpleural pressure positive. So in this example that we're utilizing, interpleural pressure is now 20. Now velar pressure is 40 in this example, so I still have a positive transmural pressure gradient across the alveoli. The alveoli are not collapsing. But as I work my way outward toward the mouth along the airways, airway pressure is becoming less and less. We have to have a pressure gradient for flow. Now notice at this point, transmural pressure gradient is -5. Airway pressure is 15, interpleural pressure is 20. 15 minus 20 gives me a -5. So now I have a negative transmural pressure gradient, which is going to cause airway compression. We call this the dynamic compression of airways. Once we get to this point, this dynamic compression, the airflow is no longer dependent upon effort. So what's driving the airflow? Recoil. Now remember, As lung volume falls, recoil falls. So as I get dynamic compression of airways, since recoil is driving the flow, as the lung volume falls, the flow falls. And we will see that characteristic aspect when we do a flow volume loop in just a few moments. So this is the physiology of what is occurring during a forced expiration, part of pulmonary function testing. Okay, how do we use this to diagnose? On the right is the normal that we already walked through. On the left is an obstructive patient. All right, how do I know this patient is obstructive? Well, notice their FEV1 to FVC ratio is 50%. You should be able to blow out at least 80% of your vital capacity in the first second. So if you look at the normal, they blew out 80% as we walked through. They blew out 4 liters of the 5, so that's 80%, so that's normal. 80% or greater is normal. The obstructive patient has elevated airway resistance. So the flow parameter, FEV1 to FVC ratio, is low. Diagnosis, obstructive. We have low flow, diagnosis, obstructive. Now, there are some other lung volume changes here, things that we should appreciate. Forced vital capacity may go down, typically goes down in obstructive, but we diagnose obstructive by the low flow. In addition, FRC, TLC, and residual volume are going to go up. But the one that really drops is that FEV1. Now, let's think about why those volumes go up. As we talked about on a previous slide, airway resistance and lung volume are inversely related. So as lung volume is going down, airway resistance goes up. It goes up in everyone. While an obstructive patient already has elevated resistance on top of that. So it becomes very difficult in an obstructive patient to blow air out. And thus they get more trapped air. Residual volume is going to go up, which is going to increase FRC. And if residual volume is going up and up, then total lung capacity goes up. Hopefully that makes sense. Obstructive patients have difficulty getting the air out because of elevated airway resistance. Now, on the STEP exam, forced vital capacity is going to vary from individual to individual. So they will give you this as a percent of predicted, or they will give you a range of volumes that's, quote, normal. And that's how you compare to determine if the forced vital capacity is low or not. But again, you always use the patient's forced vital capacity and the patient's FEV1 to calculate the FEV1 to FVC ratio. Normal is 80% or greater. Low FEV1 to FVC means low flow, means obstructive, Now, the other thing that we do, our big obstructive diseases are asthma, chronic bronchitis, and emphysema. So expect to see pulmonary function testing before and after bronchodilator therapy. Okay, that's a beta-2 agonist, oftentimes albuterol. If you have an obstructive patient and then you administer a bronchodilator, a beta-2 agonist, if the flows get markedly better, then diagnosis asthma. If they don't, then the patient has COPD. COPD means either chronic bronchitis or emphysema. And the reason for that classification is most likely because most patients have some combination of emphysema and chronic bronchitis. So you just put it under the umbrella of COPD, chronic obstructive pulmonary disease. Okay, for restrictive patients, again, on the right is normal. To the left is our restrictive patient. And hopefully the thing that jumps out to you is the markedly reduced volume, low volume. But notice, in this subject, we do have low volume, but their FEV1 to FVC ratio is normal. In this example, it's 88%. So it's above 80%, means it's normal. They have normal flow, but low volume. The lungs are restricted from expanding. all the lung volumes are going to go down in a restrictive patient. And hopefully that makes sense, because if their lungs are restricted from expanding, we won't be able to hold volume. So low volume is the problem in a restrictive patient. Their flow will be normal. FEV1 to FVC oftentimes is pretty high, but bottom line is greater than 80%. So normal flow, low volume, restrictive. And again, some examples: interstitial pulmonary fibrosis, sarcoidosis, asbestosis, silicosis, the osis. All right, here's a table illustrating what we just described. Notice the variables. The key variables are the volume, forced vital capacity, going to be down for sure in a restrictive patient. Likely down in an obstructive, but doesn't have to be. But flow, FEV1 to FVC, will be down in an obstructive patient, no doubt about it. And it will be at least normal in a restrictive. They may tend to be on the high side. You know, that percentage will be high, but the key point: normal flow, low volume, restrictive. Low flow, obstructive. And once again, total lung capacity, FRC, residual volume. Obstructive patients have problem getting the air out. Therefore, those volumes are going to go up. Restrictive patients, their problem is volume, so those volumes are going to go down. So that's our big comparison. Key things to focus on are forced vital capacity and the FEV1 to FVC ratio. But do know those three lung volumes highlighted in the purple, which direction they go in obstructive and restrictive. And if you can remember that obstructive patients have problem getting the air out, then that can help you to remember which direction their lung volumes go. Restrictive patients have problem getting air in. All right, they can't get enough air in, so those volumes go down. All right, here's a flow volume loop. Flow volume loop. On the left, we're going to start at total lung capacity and go down to residual volume. It's the exact same pulmonary function test. We're just plotting the data differently. Flow volume loop. We have flow on the y-axis and volume on the x-axis. The upper part is expiratory and the lower part is inspiratory. Now, I wouldn't worry too much about the inspiratory curve. So let's pay close attention to the expiratory curve. Initially, what happens is flow goes very, very high. Remember, you're blowing air, you're blowing air out hard. So initially, you get this very high peak flow. And then notice, there's a steady decline in flow as lung volume goes down. Now, what we said earlier on the physiology, what's driving the flow when we're getting this dynamic compression of airways? This is a forced expiration, so positive interpleural pressure. Recoil is driving the flow. So as lung volume falls, flow falls in a nice, steady, linear decline. Because as lung volume falls, recoil falls. Since recoil is falling, flow is falling. So this portion of the curve is what we call the effort independent. It's no longer dependent upon effort. It's the lung recoil driving the flow, and lung recoil is a property of the respiratory system, no longer dependent on effort. Now, one of the things that happens to this effort independent portion is it will scallop or bow inward, as illustrated by the dashed blue line. This is very characteristic of an obstructive patient. All right, let's think about why that curve does that. Well, if I pick a lung volume, any lung volume on this effort-independent part, the scalloping shows that I have less flow. So compare the scallop to the normal. As you can see, at that lung volume, you have less flow. Less flow, obstructive. Less flow, obstructive. So very characteristic scalloping of the effort-independent portion of a flow volume loop. Pulmonary docs love flow volume loops. Here are three expiratory curves of flow volume loops. Now notice we're just looking at the expiratory. In green in the middle we have our normal. The purple to the right is restrictive. The blue to the left is obstructive. So these will be characteristic changes in a nice comparison of obstructive, restrictive, and normal. Now obviously you may not be given the labeling of this. So we have to look at the key characteristics that we see that define the two pathologies. Number one, notice that the blue, if I were to draw a straight line, steady decline like I see in green and purple, you can see the scalloping on the blue line, the effort-independent part, very characteristic of an obstructive patient. Other characteristics, we always start this test at total lung capacity. So this point on the graph for the three different graphs represents total lung capacity. You can see that total lung capacity goes up in obstructive, goes down in restrictive. What's left in the lungs after we blow out all we can blow out? Well, that's residual volume. Notice that the restrictive patient has a low residual volume. The obstructive patient has a high residual volume. So those are the key characteristics that show us why we diagnose the blue line as obstructive and the purple line as restrictive. Again, this is the expiratory portion of a flow volume loop. Very diagnostic.